Live now.
Good evening, everyone, dear Foxians, and all we are watching this Foxy Gyan Pravah series that is daily podcast, and it is initiative by our visionary president Foxy Dr. Sunita Tandulwadkar Madam. I, Dr. Brizwala Tiwari, Environmental Health Committee Chairperson, welcome you all to today's 214th episode of daily podcast Gyan Pravah. So 213 episode have been done and today we are having 214 episode and today's guest is Dr. Mohit Bhandari my topic is from surgery to sustainability, breaking the cycle of obesity. And Dr. Mohit Bhandari is president of IRCAD, Institute of Research into Cancer of the Digestive System. This is for the first time in history of meticulously designed series of daily podcasts on various subjects by experts to improve women's health. Brain behind this beautiful concept is none other than President Dr. Sunita Tandulwadkar Madam. So let me invite our dynamic president, Foxy Dr. Sunita Tandulwadkar Madam. And one word I would like to say Nabhuto Nabhavishyati, madam is like that. So many projects are going on in Foxy this year. Sampurna, Aparajita, Know Your Number, Pace, Eagle, आरोग्य योग यात्रा एंड मैडम का जो नारा है हर घर फॉक्सियन that is really important and we are reaching out to every corner from north to south, east to west, every corner, small societies everywhere. And madam is particular about the Sampurna Swasth of Women's. So ma'am is a global feature in OBGY. Her contribution extends beyond operating route. She is leading Foxy as President IAG and Founder President Society of Ovarian Rejuvenation and President-elect ISAR. Ma'am's work has been widely recognized by numerous awards.
Rijwala, it is yours and Mohit's podcast.
Madam,
So we cut down. And thank you so much for 30 committee chairpersons doing 30 designated days. This podcast, we could never imagine when we designed that really what it will be. And when we used to be on number 7, number 8, we used to feel when we will be reaching 200 plus. And continuously, every day, sharp 8 p.m., our podcast starts. Academic, non academic, spiritual, philosophical, from any background, the global leaders from India or outside. It's absolutely a huge collection, and I'm thankful to each and every chairperson who absolutely work with me, obeys whatever my decisions, or always try to do their best whenever any project comes in. And I'm so thankful and proud of you, Birish Bala. I know you are today for another project. You were in the city of Pune and in the hotel room. And I had so many other work, so that, but I could not be with you all. I know many of you stayed back, but I could not join you all for dinner. But I'm sure you all are doing such a good job, leaving the family, friends. 8 o'clock, you have gone in the room and you are taking this live podcast. Thank you, Dr. Mohit. Lovely to have you on a Foxy platform. And I'm sure this podcast will be one of the most educative podcast of our year. Thank you for being here. Thank you. Thank you for your time.
thank you, ma'am, for your gracious presence and blessings. Thank you so much. So now I will be introducing Dr. Mohit Bhandari. Dr. Mohit Bhandari is global feature in bariatric metabolic surgery, and he himself is fitness enthusiast and more than 21,000 bariatric surgery he has done. And not only bariatric surgery, he is motivating patients to go into um, active lifestyle, and whenever required then only he is doing surgeries, otherwise he is motivating patient to do exercise, to do other things to reduce the weight. And he is teaching everywhere globally. He is having around 6 centers across India and internationally, and he is robotic surgeon as well. So I welcome Dr. Mohit
Thank you. Thank you
for
so much.
today's podcast.
Thank you. Thank you. Dr. Mohit, our protocol is you both will be in the frame and I'll join the viewers link to watch you and listen to you. Enjoy your podcast and your dialogue. Thank you.
Yes, thank you so much.
So, very good evening, Dr. Mohit Bhandari.
Mhm.
And first of all, thank you so much. You are having so busy schedule in trainings, taking care of post-op patients, going here and there for teaching. In spite of that, you have accepted my invitation on behalf of Foxy. So, my sincere thanks to you. So, let's begin with our discussion because the topic is really important. Um, India is capital of obesity, we can say, and so you have performed more than 21,000 bariatric surgery. That is an extraordinary achievement. What first drew you to this field? Because I think when you have opted this subject in your PG, if I remember, you have been taken first cardiac surgery, and I was really everyone was thinking you left that time the cardiac was really like anything and you opted this, so it was vision beyond imagination. So you what first drew you to this field?
So, ma'am, actually, I'm not a bariatric surgeon by choice. I'm a bariatric surgeon by chance, and it's more serendipity than actually taking a call, like you said. So, yes, I went for cardiac surgery, and I was very fascinated because with the cardiac surgery, because during those days, I distinctly remember that the then Prime Minister, Shri Manmohan Singh ji, underwent a cardiac bypass, and AIMS was the center. So it was one of the best cardiac surgery center. But 6 months into my fellowship, the blanch did not lured me enough to make me continue. Maybe I could not handle the stress. I don't know. I will not give excuses and reasons, but I quit. And then I went to IRCAD in Strasbourg to train myself into advanced colorectal surgery. But the only thing left there was bariatric surgery. And so I had to take that. So it was never vision, like you said. I'll be very honest. It was always serendipity. But somebody inspired me during that time to be in the field, and that was Professor Malfobi. And I met him during a course at IRCAD, and he said that if you become a colorectal surgeon or a cancer surgeon, you will always take away from the patients because at best these surgeries are just palliative. But if you do weight loss surgeries, you as a surgeon will have that capability to show somebody that light at the end of a dark tunnel. I was very impressed because I saw how his fellows, his mentees used to treat him like God. And he was that Phoebe pouch gastric bypass guy I used to read about in Love and Bailey textbook of surgery. So I followed him. And that's how it started. Came back to India and started the Mohawk Center for Bariatric Surgery. And it was a really tough time because the anesthetist, the nursing staff, the intensivist, they never saw such huge patients. They would never give anesthesia fitness. So it was tough. But yes, to answer you shortly, it was more than serendipity than any vision.
But now you are global figure in bariatric surgery. I think this much amount of work have never been done. You are not only a surgeon, but also a fitness enthusiast. And I remember, I know that you run 10, 11 kilometers daily. And so, how do you balance such a demanding surgical career with your personal fitness regime?
So I think I was not very particular about my health till until 2020. 2019, I would say I was operating like day in and day out, traveling to 5 cities in 3 days, not paying attention to my own health. And I should accept that with all honesty and humility that most of us, surgeons, physicians, gynecologists in the field of medicine, we do not pay attention to our health. And then I had a personal health problem, a personal health debacle. I had a myocardial infarction in early 2020, and that changed my life completely. That actually helped me to realize that no matter how much we may toil, if the health is not on our side, we will never enjoy the fruits of the success we have. And so then I started completely, I revamped my lifestyle. I changed myself completely. My priority was that every day I should get up, devote at least 1 to 2 hours to my own body. And, that's how. So it required a shock to change. But then, with my experience, I can tell you that it's being one of the most life-changing event which completely changed my mindset. I started running, I started exercising, I started going to the gym, I started leading a fit life. And believe me, I can tell you that the day I started to train for marathons and half marathons, now I have so much of energy. I can operate the whole day without getting tired. So I actually realized that when I started paying attention to my own health, uh, it was forced. I was in a much better position to uh, think about my career, think about myself, and also think about my patients to prove them as an example. Madam, in this present era, I think leaders are just preaching. They never live by an example. And that's the problem why public at large lose faith in leaders. Because leaders, they may be political or religious or maybe lifestyle coaches. If they themselves lead by example, they create history. And that's why when I started to run every day, my patients started to get motivated. I still remember just after 3 to 4 months after my myocardial infarction, I ran a full Mumbai marathon. So that's the thing I did, and that was the motivation I got. It was forced, but yes, that led me to a right path in my life.
So this personal commitment to fitness influenced your counseling also about lifestyle and obesity.
Absolutely. I think even though we may do any kind of treatment for obesity, it might be drugs, it might be bariatric surgery, or non-invasive methods like balloons, they are never successful without a lifestyle modification. And obesity is such a chronic disease, just like cancer, that no matter how strong the modality of treatment is, if the lifestyle modification is not in place, it is not going to work. So that helped my patients. They used to say that, did you underwent a bariatric surgery? And used to say, no, I did it myself, my own way. And I'm still doing it every day. So running 10 kilometers a day or going to a gym is just like my way of doing a gastric bypass on my own self. And so they really got motivated. And something which motivated my patients the most, if you ask me, is that they never gave me an excuse that, doc, we are so busy, because they know my lifestyle. They know that I'm operating out of 5 different cities. Tonight I'm in New Delhi. The next day I would be in Hyderabad. And the very next day I would fly to US to deliver a lecture. And my patients, they see everything, because now everything is on Instagram, social media. And so when they see me exercise every day with that kind of lifestyle, they would never make an excuse.
Great. It's great that your own example, patient get more influence and it coming from your heart only. And you started at very late age, but you are persistent in that. That is really great to know. Dr. Mohit, coming to obesity, that there is a rising, sharp rise in obesity worldwide, and India is not exempted from it. And obesity is not just obesity, it is more metabolic disease, so many related metabolic problems, diabetes, fatty liver disease, hypertension, in women PCOS, and adverse reproductive outcome, infertility. So what are the driving this forces behind this surge of obesity?
I think it's more about lifestyle. Now imagine, there were never so many food apps. The availability of food has become so easy. Uh, the amount of physical labor we have to do is so less. Everything has become easy, and the amount of stress and competition has also increased. Now imagine when we were writing our competitive exams to the day now, the competition is ever increasing, the availability of food is increasing, and the amount of time we are involved with our mobile phone and the gadgets, which give us that quick dopamine surge. This was not present like 30 years back. No, it was not there. Now it is there. And so I think there is this sudden change in environment, which has affected even our genetic and metabolic makeup. And so you see, and as an infertilologist, madam, you also see a steep rise in infertility. It never used to happen 30, 40 years back. I mean, imagine the number of IVF cycles happening then in that time. I can understand that there is a lot of public knowledge available on social media and increased awareness. But the incidence of infertility is rising steeply. The incidence of obesity is rising steeply, all the non-communicable diseases. And the best example is that we do not have the same kind of lifestyle, the same kind of issues we had back then 30 years ago. Completely changed. So this is going to increase only in India, as far as we see it.
So, as you were saying, it is not beyond genetics, lifestyle matters. So, do you feel there are environmental factors that is also pollution and all that is affecting?
Absolutely. I think pollution is there. We are also seeing certain very important pollutants which are involved in damaging thyroid glands. We see a very high incidence of subclinical and clinical, both hypothyroidism in Indian females. So I think definitely that has a role. And we saw that latest study done on the youngsters in the city of New Delhi, where their lungs are affected with decreased lung compliance, which affects their physical activity and which also affects the compliance overall in exertion. So I think a lot of these factors are responsible. And the most important thing is that we need to go and research at the level of our gut microbiota. Believe me, if we take fecal samples of youngsters now, and then when we were youngsters 30, 40 years back, you will see an entirely different set of gut microbiota then and now. And I'm not just talking fiction. This is the reality, has been proven by a lot of publications that the gut microbiota has completely shifted towards creating the kind of environment where we are obese, we have more fat on the liver, we have more fat on the visceral organs, and the amount of gut dynamics in terms of the microbiota has completely changed. So when people come and ask me, why are we gaining weight suddenly? Doc, what has happened? I am actually, not able to tell them what has exactly happened, because it's a complete mix of so many factors: environmental toxins, pollutants, genetic, epigenetic changes, change in lifestyle, and so many others, that such a complex mechanism is behind the bile acids and bile salts. We never used to talk about them. Now we are talking about the bile acids and the bile salts, the enterohepatic circulation. So this is all science, and a lot of research is going into it. Everything has changed over this last 15 years, especially.
Yeah, very rightly. Microbiota is a big thing affecting everything, and it starts from gut. And I think endocrine disturbers are many toxicants present in all this canned food and water pollution, air pollution, everything is there. And so, rightly said by you that hepatic fat and bile and all that are so it is the multiple factors behind this obesity. Previously, we were used to see genetic, epigenetic only, but the environment and lifestyle, of course, that is the major thing. You have already said that air quality and environmental toxins are being linked because this is a vicious cycle. I think the lung compliance is poor, they cannot do activity, and then obesity. So it is the vicious cycle. So, do you feel notice any difference in obesity and metabolic health trends between India and other countries, where you are operating in many countries nowadays?
Yes. Yeah, there's a lot of difference. In India, we are all cursed because I would tell you a very interesting thing, that uh, when we gain a little bit of fat, the disease like type 2 diabetes and hypertension would definitely come. It's known that the more amount of fat we have, and especially the visceral fat, the diabetes and metabolic syndrome is going to come. But the problem with Indians are that we have very less muscle mass. So the moment we gain 10 to 20% of extra fat, we have diabetes. And the data suggests that in Indians, this diabetes peak at a BMI of 29. And the metabolic syndrome also peaks at the same body mass index. So unlike the Caucasian population, the Asians and specifically Indians, also I would not include the Chinese here, specifically India and Pakistan and Bangladesh. We were the same country, almost the same kind of food in the past, some genetic linkage. We have just 5% increase of fat in the liver. We have NAFLD. A little bit of visceral fat on the mesentery, close to the spleen, we develop diabetes. And all this peaks at a BMI of 29. Now, the same thing in Caucasian would peak at a BMI of 40. So imagine that even if they become obese, their muscle mass sort of protects them from insulin resistance. But we do not have that much amount of muscle mass. Our build is very different. And so even a small percentage of increase of fat is damaging everything. And I can tell you that not only from the perspective of macrovascular changes, but it's also microvascular. So for example, an individual at a BMI of 29 or 30 who is a diabetic will develop retinal changes rapidly in India. And the same amount of retinopathy will take years to develop in a Caucasian, specifically in Europeans. So it's not just related to larger organs, it's also related to our vascular makeup. And that's very troublesome, because I, for that matter, operate upon diabetics who are just BMI of 29 and 30, and they respond so well to gastric bypass operation. Imagine these kind of BMIs, they are not even permissible to be operated in US, because there everything is like 40, 45 plus. In Africans also, especially the American Africans, they have the same thing. They have a lot of muscle mass. They don't get diabetes so easily. And so even if they are huge, they get saved from a lot of diseases like diabetes, hypertension, and all the problems in them will start to happen above 40. So till 40, they do not bother. The build is that way. So that's a big problem with us. I remember most endocrinologists showing that beautiful photograph. You'll get it on Google. That there are two endocrinologists sitting in the same frame. One is an Indian endocrinologist, another is a Caucasian. Both of them have exactly the same weight, exactly the same body mass index, but the percentage of fat varies. Like Indian endocrinologists had 3 times more fat than the Caucasian. And that is responsible. And that's why, I would tell you, and you would agree with me, that weight and body mass index is not a very good indicator of obesity, because all of that mass can be a muscle mass, So, that's the problem. And unfortunately, we treat body mass index like some saga. It's like so eternal to us that we always try and, religiously use it to treat obesity, but it's not a correct indicator of obesity.
So that is really a big myth in mind of people, because they are calculating their BMI, and if it is 26, 27, they feel they are okay. But the information you just shared, that the muscle mass and visceral fat, it is really challenging. Lean muscle mass and excessive visceral fat, that is challenging for Indian people. And like 29 BMI and more than 35 BMI of Caucasian is not causing that much metabolic issues which we are having at 29 BMI. So
absolutely, I think I have seen most Indian surgeons and even physicians now they have changed. So initially we used to say, "Oh, stand on the weighing machine," like 15 years back. Now we say, and then later on we said, body mass index kara lo, BCA kara ke aa jao, do a body composition analysis, and now everybody has shifted to DEXA. So we are saying no more BCA, no more weighing machine, go and do a DEXA, Get me your lean body mass, get me your exact amount of total body water, get me the exact muscle mass, fat mass, which is visceral and which is subcute, and then we will decide what kind of obesity you have. So yeah, everything is changing as we are learning.
So your surgery depends on what amount of, not on BMI, it's amount of these analysis. So just can you tell us about the procedures you are doing, different type of procedures?
Yes, so we have both surgical and non-surgical procedures. So surgical procedures, everybody knows, gynecologist knows more than surgeons now. Gastric sleeve, a gastric bypass, or one anastomosis gastric bypass. These are gastric sleeve is very common. Most of the surgeons, they do a gastric sleeve. It's a very successful surgery. Gastric bypass is the conventional one, the old one, where you have two anastomoses. And now we have the third one, which is known as a mini gastric bypass or a one anastomosis gastric bypass, where we have a long pouch and just one anastomosis. All three are very, very, very successful bariatric surgeries. In olden days, we used to do a duodenal switch or a biliopancreatic diversion, which is not done now because of the malabsorptive propensity of the procedure. If we talk about the non-surgical procedure, a swallow balloon or an intragastric balloon, very commonly done, a non-surgical procedure. And the other one is an endoscopic procedure where you put an endoscope and then inside the stomach, you can suture and decrease the capacity of the stomach, which is called as the endoscopic sleeve gastroplasty. So these are, in nutshell, the kind of procedures we do.
So how do you decide which surgery for, yeah, it is patient choice or you are going to decide it?
No, I think we have a very good algorithm, and even to gynecologists listening to the podcast, I can share, and it's very logical because when a patient come to you, you can decide. So usually the non-surgical methods would only work between a BMI of 30 to 40. And I know that the BMI is not a very good criterion, but unfortunately, with 100% insurance, we have to have some objective parameter. So let's choose BMI for now, just to simplify things and just for a practical aspect of it. So 30 to 40 BMI, let's say it's a very good case for a non-surgical method. Do a swallow balloon or an endoscopic sleeve. They work, and these patients lose 15 to 20% of their total weight. Anybody above a BMI of 40, absolutely bariatric surgery. Even the new drugs, the Ozempic and the Mounjaros, would not work at that body mass index above 40. Surgery is the gold standard, and surgery will always remain there because it causes good 30 to 40% of total weight loss in that area. Also in surgery, I would go a step beyond to explain you is that if the patient has pre-existing history of a gastroesophageal reflux disease, which is called as a GERD, a gastric bypass is a much better option because it diverts the bile, the conventional gastric bypass, and it treats the gastroesophageal reflux because you remove the pylorus from the equation. For patients who have very bad liver, the NAFLD thing. For patients who are young and have PCODs, like you get all these patients, a gastric sleeve is the perfect option. So this is, in a very gross way, how we decide what procedure needs to be done where. As I clearly said, 30 to 40 BMI, do endoscopy, do drugs, do lifestyle modification, whatever, everything will work in that bracket between 30 to 40. The moment the patient crosses a BMI of 40, only surgery will give a long-term and a sustained weight loss.
Right. So right now you were saying about the all Mounjaro and all drugs. So these are like very much into big way in market. They are blockbuster weight loss drugs. What makes them so effective compared to like other older medications and how they work? A little bit more about this thing also.
So, great question. What makes them more effective than the older drugs? So, I think the Mounjaro and Ozempic, for all of us to understand, they are the GLP-1 analogs. So, what is GLP-1? Now, imagine if I do a gastric bypass on a patient. Let's talk about bariatric surgery. So, I will take the story from that area. So, imagine we do a gastric bypass on a patient in your hospital. And when, madam, I will do the gastric bypass, within 48 hours of doing the gastric bypass or bariatric surgery on one of your patients, if I take his blood samples, this GLP-1 hormone is million times than it was before surgery. So the scientists thought that whatever you do with bariatric surgery, because of which patients loses appetite, can we synthetically produce that hormone which comes after bariatric surgery in the patient? And then a very famous endocrinologist, Professor David Cummings, he said that the research says that there is a lizard in the forests of America known as the Gila monster. That lizard saliva contains the same hormone, exactly the same hormone, almost same, which is produced in human beings when they do a gastric bypass bariatric surgery. They extracted that saliva of Gila monster lizard, sent it to the biomedical area of biomedical researchers and biogenetic scientists, and then they produced this drug called as the GLP-1 analog. The first drug produced was liraglutide, which came by the name of Victoza long back, which we have been using, not very effective. But then they were able to exactly pinpoint the same kind of molecule which is coming after gastric bypass. The name of that drug was semaglutide, which comes by the name of Ozempic now. In fact, they went a step further. They said, let's extract all the hormones which are secreted after the bariatric surgery from the human being. So they found GLP-1, they found GIP, and they found glucagon. So after semaglutide, they again went and produced the GLP-1 and the GIP combination, which is called as tirpazetide. It's a twin cretin. These are twins, GLP and GIP, both produced in human after bariatric surgery. And now they've extracted and they're producing it synthetically outside the human body. That's known as the Mounjaro, which is very effective. Half of the Bollywood is on Mounjaro, half of the world is on Mounjaro. And these drugs are damn effective. Not as effective as bariatric surgery in real clinical practice, 10 to 15% of total weight loss at 2 years.
Okay.
Which means if there is a 100-kilo guy and he takes it for 2 years, at the end of 2 years, he would lose around 15 to 20 kilos. So that's how the history of these drugs came into.
So after listening your work behind this drug, I can understand they cannot substitute need of surgery if BMI, like so-called BMI, as for we are taking BMI into consideration. So these drugs will take 2 years for reducing 10% weight loss. And so it is, if a person is having so much weight, they need to go for bariatric is better.
Again, I would say very, very important question and an important message. Madam, these drugs are forever drugs. You know what are forever drugs? You cannot leave these drugs. If you leave these drugs even for 1 month,
okay,
the entire weight comes back again. So if anybody wants to take Ozempic or Mounjaro, there are two very, very important caveats. And I always say that. And if the physician says that, the patient does not listen to him then, but they should listen. The first important caveat is that these are forever drugs, should never be stopped. The data suggests that if you stop these drugs, almost 50 to 60% of the patients regain all the weight back they lost within a period of 2 to 6 months. That's first caveat. The second is that at 2 years, the clinical studies have suggested that you lose 18 to 20% of total weight. Correct? So if you are 100 kilos, you will lose 20 kilos in 2 years. But that's the studies out of a clinical trial data. In real clinical practice, the weight loss is not that high. It is 10 to 15%. Obviously, in clinical trials, we have a lot of observation, a lot of surveillance. But in real clinical practice, our patients are indisciplined. All of us are. So, but it takes nothing away from these drugs. These are fantastic drugs. Use them between a BMI of 30 to 40, or even at a BMI between 20 to 25 to 30 if you are a diabetic. Use them judiciously under physicians or surgeons' guidance. And these are forever drugs. You can never stop them. As of now, what the data, there is no legacy effect to this surgery, or to this drug. What is the legacy? Father dies, he leaves the land to the son. The son have that legacy. Son dies, he leaves to his son. So that land can carry as a legacy from one generation to another. But if you stop these drugs, there is no legacy effect. You gain all the weight back.
So, other than this, they have to be taken forever.
Yes.
They are having other side effects. Can you just tell about the precautions and all that?
So I'll, in a very simple language, I'll explain. So these drugs, the mechanism of action is that they would delay the gastric emptying. So you eat the food will be inside your gut for a long time. So you can have, total stomach paralysis, total gastric paralysis, which is called as the gastroparesis. So the food can stay there. And the same thing can happen to the bowel, also the bowel paralysis. So you can have constipation or diarrhea, both, depending upon how you, sort of adapt to these. You can have gastric stasis, which can cause gastroesophageal reflux, belching, burping, acute gastritis, and bile reflux. So these are certain problems which happen. Apart from that, patients who have gallstones need to be very careful, because these are GLP-1 analogs, and GLP receptors are there in all parts of our body. They are on thyroid, they are in our brain, they are on our gut, our pancreas. So they will stimulate even on our bones. So they're going to stimulate the GLP everywhere they are on the body. So be careful about pancreatitis. If you have abdominal pain, please immediately come to us or go to any physician, get an ultrasound, get a serum amylase. So these are certain very, very important precautions. Anybody who has a history of thyroid cancer in the family, like especially the medullary carcinoma thyroid, or the Men's syndrome, these are completely contraindicated, because studies in rats have shown that they cause thyroid cancers. There are recent reports of Ozempic causing some blindness. I don't take them very, very seriously, because these are more because of acute glycemic control due to these drugs. I don't see that there is such a large sample that people should be scared of blindness because of these drugs. It's more of a media hoax than, a real scientific basis to it. But yes, pancreatitis, especially gallstone pancreatitis, total gastric paralysis, severe constipation, these are some of the more important, commonly, and nausea and vomiting, obviously, some of the more important common side effects. But having said that, that's why these drugs are taken in a graded manner. You start with the lowest possible dose, let the tachyphylaxis set in, and then you go to a higher dose, and then you go to a higher dose. So to come to therapeutic dose of 15 milligram for Mounjaro, we take at least 6 to 10 weeks, So people do not follow protocol. They buy it from the black market and self-inject. That's not the correct way to do it.
So basically, these drugs are taken as secrets of Hollywood, Bollywood weight loss.
Yes.
And that's why it is marketed so much. But they are needed to for long term, and judicious use and judicious prescription is important. So much monitoring with these drugs is required, and gradual setup protocol is required. So, if we compare medicines for weight loss and bariatric, post-bariatric surgery, like with medicine, you have to be in everything, like to follow and continue forever drug. But after these different types of metabolic surgery, rather not to say bariatric, it is metabolic surgery. So, what precautions one need to take?
So if drugs are forever drugs, bariatric surgery is not a forever surgery. So let me talk about negatives of bariatric surgery. Even bariatric surgeries have weight regain. Almost 50% of our patients regain some weight 8 to 10 years after bariatric surgery. But what's the good thing about that? They never regain all their weight back. They just gain 10 to 15 to 20% of the lost weight. That's the beautiful thing. The second thing is, most of the patient will still maintain good resolution of diabetes, hypertension, sleep apnea after bariatric surgery, even if they have gained some weight. So still, if you talk about the effectivity and robustness, bariatric surgery is way up at the top there, but it still requires lifestyle modification in a very aggressive way. So I think the future would be combination of bariatric surgery and these drugs. In fact, drugs are marrying surgeries and surgeries are marrying drugs. So both in combination, is going to be the future. What we are seeing, all our weight regains who have little bit of 5, 7, 10 kilos of weight regain respond very well to these injectable preparations. And that's why I'm saying that these drugs are complementing us surgeons in a very big way, that first we are able to keep that trust and the faith of our patients in our program post bariatric surgery, and we never lose our patients.
So it is the post-surgical follow-up your team is providing that is really very important, and that is keeping them in that mode to keep fit, and they get inspiration from you. So we know surgery is life-changing, but prevention is better than cure. So what lifestyle measures could help people avoid obesity-related metabolic disorder uh, after this surgery?
So I think what we recommend usually is minimum of 2 days of strength training, resistance training, because we are scared both with drugs and surgery that patient lose a lot of muscle mass. So you know that there's a lot of sarcopenia and a lot of patients with they complain that they've lost all their muscle mass. You have heard about Ozempic facies. You have heard about patients not looking good. They have all sort of problems. So I think the best way, whether you take these drugs or you do surgery, do minimum 2 to 3 days of resistance training, strength training. Take 1.5 gram per kg body weight of protein, which is very, very important. These two things. And third, try to do some aerobic zone activity like walking, running, cycling, or jogging, but with measurement of your heart rate. If these three things are done, where you measure your heart rate, I mean, I am fed up of people saying, "हम kitchen में ही पैदल चल लेते हैं." Yeah, I go for a walk in my own garden inside my house. Now, even if you go for a walk and your heart rate is like 85, it's not. So I always say brisk walking with heart rate monitoring is a good aerobic activity, around 120, 130 minutes per. I'm just talking about an average 45, 50-year-old guy. It depends upon what is the aerobic zone of that particular guy, depending upon his or her age and sex. But that's one thing. Resistance training twice to thrice, 2 to 3 times in a week is one. Half an hour is good enough. And third, 1.5 gram per kg body weight of protein. So this is something which we prescribe to all our patients on drugs or balloon or surgery. That's one thing I'm very particular about. Good sleep. I'm sorry, there's a fourth thing. A good sleep is very, very essential. If they have sleep disturbances, we often put them on melatonin or drugs to sleep well. That's what we advise.
Yeah. Yes, very correct, Dr. Mohit, that good sleep is important for recovering from any sort of these things. So, very correct that lifestyle, again, back to lifestyle, exercise, diet, and sleep. These work after surgery and medicines. So, any interesting case story which you would like to share for the viewers?
There are a lot of interesting cases. The first important thing is that I want everybody to know, and don't take me, that I'm non-scientific, but I'm saying everything on a very scientific basis, is that exercise does not cause weight loss. That's the first and the most important thing. No matter how much you exercise, you can never beat a bad diet, or you can never burn the amount of calories to go into a negative deficit till the time you go on a diet which is calorie restricted. So first of all, for people who believe in the fact that I can exercise as much as possible and I can burn 4,000, 5,000, 6,000 calories in a day, I did half Ironman, and after the entire Ironman, my calorie burn was 1,800 kilocalories. People who do a full Ironman, after a full Ironman, like swimming for 3.4 kilometers, biking 180 kilometers, and running a full marathon, they burn close to 4,000 kilocalories. So imagine if you feel that you can burn the amount of calories you consume, it's not possible. Exercise is for your lung fitness, for your basal metabolic rate, for your compliance, for your bone growth, for your aerobic fitness, and for your heart. If there's one thing which affects the weight loss in terms of exercise, is building more muscle mass, but I think that's also too hyper rated. even if nobody can grow 15% muscle mass overnight. It's difficult. You just gain by 2 to 3%. That's also, super disciplined people. So first of all, both strength training and exercise, they have different purposes than what people think. The special case I'm going to mention is about a 300 kilo guy. Now, this guy eats like both of us, maybe, or maybe less than us. And then he gets admitted to our hospital. We monitored his diet. Everything good. But that's how genetic work. You can have a guy who gains some weight because of a bad lifestyle, but eats the same amount of food. And then you get this patient on your table. And when we did many above 300. But the first one I would like to mention here was the toughest one. This is a Mauritian guy, came from Mauritius. And the problem with us is we could not operate him on the OT table because he could not come on the OT table. I did this bariatric surgery on the bed because the patient could not come on the OT table.
Okay.
It was challenging to take venous access. It was challenging to intubate this patient. We require at least a team of 32 people to shift patient both on the bed and change and turn the positions. But we send him home well. So these kind of challenging things, and even laparoscopy is very challenging. You need extra long trocars. You need to put the trocars in a way that they have minimal torque on your hands. These trocars can break through in the mid of the surgery. So it's very challenging, both to do these procedures surgically and both to make patients fit for surgery. That's one case I would like to mention. But why I want to mention this case is that this patient did not eat to become 300 kilos. And also he cannot exercise that much that he loses all that 300 kilos. So this is the kind of reality. Yeah.
So that is genetic factor.
Genetic, hormonal, environmental, sometimes unknown.
Yeah.
And most of these patients who get to that kind of weight, like 200 plus kilos, it's absolutely unknown that why somebody eating the same amount of food has reached just 150 kilos and somebody has crossed 200 kilos. So we are never able to, as I said, the answer would lie at the cellular level, maybe microvascular level. So we are still trying to find out what happens and how these things happen.
So like right now you were saying that it is really challenging. I can imagine you cannot take patient on proper OT table, the trocars and cannulas, venous assays, intubation, everything is challenging. So now you have been a pioneer. I must say, robot assisted bariatric surgery, robotic surgery, you are doing in so many places. So a little bit about that and how the technology changing outcomes for patients with obesity and metabolic disease, for the patients and for the surgeon as well.
I think robotic surgery is not the future, it's very much here. So straight stick laparoscopy, the days are already gone. In 2 years, we're going to see that all these surgeries would be done by robotics. For morbidly obese patients, it's very, very easy to operate by a robot because the morbidly obese patients and all of us, even as gynecologists, we know that if we have a super obese patient where we have to do a hysterectomy and you put a trocar there, you will have so much of torque on your hands. Now imagine if you dock that trocar on a robotic arm. The robotic arm can lift the abdomen by a robo lift technique, and you will have so much of space inside with minimal amount of carboperitoneum. That's the beauty of robotics for morbidly obese. So let's not talk about a gastric bypass. Let's talk about a hysterectomy. And the hysterectomy which we have to do on, say, a patient of 150 kilos. If you have a robo, you can lift the abdomen and create that pneumoperitoneum with very less carbon dioxide because of the robo abdominal lift technique. You have no torque on both of your hands. You are sitting very comfortably on the console and doing that surgery. So I think robotics has changed the way we used to operate on super obese patients. They have assisted us in doing revision surgeries where you have multiple surgeries done on one abdomen, like maybe a hernia, maybe a lap col, maybe a old hysterectomy, maybe a 2-section scars. Everything is stuck with an incisional hernia. We can dissect with that 3-dimensional vision in a very beautiful way and suture with all degrees of freedom at our wrist. So I would say that robotics will change the way we are looking at a complex bariatric, or for that matter, any procedure. Let's talk about endometriosis in gynec surgeries. Now you have robotic staplers. You have a damaged colon. You damage it because of dissection of endometriotic nodules. You can go and fire a robotic stapler. You can go and take a suture. So, initially suturing was a task gynecs would call a surgeon. You don't need to now, because that's so simple. It's not tough anymore. You can just close it with a staple, or you can close the defect with a suture. It's easy. So I think robotics will empower both surgeons and gynecologists to do more complex procedures. And now what I'm seeing, as you correctly asked me, that with so many companies in India, now India has 7 approved robotic companies. This is leading to democratization of robotic surgery for you and me as surgeons, if we cannot afford a robo, and for our poor patients who could not afford a robotic surgery. Now you have an Indian company which is selling robots cheap. We can afford it. It's on rental model. It's on per use case model. And several other companies are going to come and foray into this field. It's going to become easier for surgeons and for patients to adopt to robotic surgery. We recently did telesurgeries with this Indian robotic system. And I can tell you that very soon this will come across hospital networks where, madam, you can sit at Indore in your beautiful hospital, and the console is close to your swimming pool, close there, and you can sit on that console and operate a patient in Bangalore, even outside the country somewhere. And your team can go as a bedside there, 2 or 3 of your members or 1 of your member, and you can operate the patient across the country. So I think telesurgery is the future, robotic surgery is the future, and whosoever is criticizing it now and not getting on the bandwagon, he will feel guilty of what he has done now. He'll feel left out very soon.
I was just going to ask you about the telesurgery only, because you are doing from India to other countries. So I think you have done so many cases. Can you just tell about the different countries where you are operating from India?
So we have done the first telesurgery for bariatric for weight loss. We did it from France, and the patient was in Indore at my hospital.
Okay.
I was in Strasbourg in France. So this was on fiber optic cables. And we were working on an open network, a public network from University of Strasbourg. So there was no special network. So it went from Strasbourg to Frankfurt, Frankfurt to Dubai, Dubai to New Delhi, and New Delhi to Indore. And we could complete this surgery in 45 minutes. It was a gastric bypass. And we are proud and honored to say that it was an Indian system, SSI Mantra, through which we could do this surgery. We have done from Delhi to Indore, and several other surgeries have been reported from Hyderabad to Bangalore, Delhi to Bangalore, Delhi to Indore, Indore to Bangalore, several other. It's easy. It's not difficult. All you need is, to shift the robot machine from active mode to the telesurgery mode, and you can perform these surgeries. The minimal amount of lag, which is permissible by CDESCO, which is the Indian body that regulates these surgeries, is 120 milliseconds. And usually what I have seen, madam, is that we have not gone beyond 60 milliseconds in any particular case. It's not perceptible to human eyes. So if you sit and do it from here, you will realize as if there's no change, as if you're sitting in front of the patient only. There's no lag which will be perceptible to your eyes, neither to anybody who is observing you. So it would be as smooth as sitting there and operating.
So the future of telesurgery now. So the things will be available in remote areas of India, I hope, in future. I think you are having one bus and that.
It's already happening. It's already happening. So we did this surgery from the bus also, which they created. We did this surgery from the hospitals also. The best thing is that if we place this robotic system in the interiors of villages in India, you can send in your team to that place as a bedside assistant to you, and you can sit at your place and operate those patients. So what the companies are trying under the model is to put these robos in all the district hospitals in small villages of India. And so once you have a network of these systems, which are very cost effective, anybody can sit and operate from a console to those areas. You can just send in your team, and that team can take care of delivering you sutures, staples, or gauze, or anything from the bedside there. And put the port and dock for you, and you can sit here and operate. And it's possible. It's not the future, it's the reality. It's already happening.
So I think that is great things are going to happen. It is already happening. So just want to ask a few more questions. Like I'm seeing something you are wearing. So what are the wearable health devices and AI tools that help people to track and prevent all this?
Actually, this is a very, very, very good question because everybody is confused. You have so many health devices. So I'm wearing a Garmin watch. Now, I would tell you that all these devices are good. If you talk to me, how to judge which is a good device. So devices can be, you can wear a ring on your hands, you can wear a fitness band, you can wear a Garmin watch or any other watch like that. If a device can track your sleep, and the sleep has to be both REM, non-REM sleep, and the deep sleep. If the device can track your sleep well, if the device can track your heart rate variability well, and continuous heart rate monitoring is present on that device, please go ahead and buy that device. So everybody asked me, kaun sa device kharidna hai? Three things you need to see. Ask that person if this device can calculate my heart rate variability. And heart rate variability is different for different people, and it's not more or less. It's a range of heart rate variability. If that device can calculate that, if the device can very well calculate your sleep, your recovery and your sleep, I mean, recovery is akin to your sleep. And if that can do continuous heart rate monitoring while you are doing a physical activity, please go ahead and buy the device. There is nothing extra which you can get out of device. There can be 100 fancy parameters like VO2 max, like, jet lag or any. The VO2 max you cannot measure without taking blood samples. It's all a farce.
Okay.
If there are three parameters, a good sleep tracking device, a good HRV tracking, heart rate variability tracking device, and number three, continuous heart rate monitoring, which is optical based sensor, go ahead and buy that device. Usually should be around 25,000 in Garmin. In other Samsung or Apple or maybe other, they might be costly or cheap, I don't know, but these three are very important parameters.
Just want to ask one more question. If you could recommend one environmental changes to city planners worldwide to combat obesity and metabolic issues, what would it be?
Grow more plants, grow more trees as much as possible. I mean, I think Fogsi has a big drive. I know that this has been, and I always say to obesity surgery organization, we should be planting trees because that's the future. That's the only, and we can start from planting a tree and it will reach to the end goal where obesity treatment meets. Foxy is doing it. Maybe other organizations should learn from you and do it. That's an inspiring cause. This is the only thing you can do. Lifestyle modifications, all of us we know we can do, but that's one thing. If we do, is simple, it's achievable. All of us can do that on our birthdays, on some special day, and it will help the environment.
So Foxy is having new committee, Environmental Health Committee, and as first chairperson of this committee, we have done plantation on this World Environment Day, and we are tracking them. They are growing. We are taking care of that, and we are following that. And they are planted in the place where we can take care. So two, three more rapid fire. Your favorite healthy snack?
My makhana.
One fitness rule you never break.
Exercise every day.
But if you miss your daily 10-kilometer run, then what is your
Not 10 kilometers, anything I do. If I'm traveling, if I'm not able to do, I will do some stretching or something. Even 10, if I can't do 30 minutes, 20 minutes, if not 20, 10, even 10 minutes is good enough. But I do not, I try, there are very rare days. And my health coach would call me and he gets surprised something has happened to me. The very rare days when I don't exercise. I feel very irritable if I don't exercise.
So it was great listening you, Dr. Mohit, and it was inspiring. And I hope our viewers will get so much inspiration. And there are so many myths broke in the mind of people, and you have cleared that what is the drug rule, what is the surgical rule, what are the preventive measure, and what are the long-term things telesurgery, robotic surgery, what is the future. So thank you so much for devoting this much time for this
Thanks
Fox
so much for
Gyan
the
Pravah
opportunity.
podcast.
Thank you, ma'am. Thank you. It's
Thank
an
you, Dr. Mohit. Thank you so much. And thank you, Sunita ma'am, for giving opportunity and our team for this flawless platform. Thank you so much.
Thank you.
Thank you. Bye-bye. Good night.
Good night.